Welcome everyone to our session. Our session is live and will be recorded, so please be mindful of your and others' privacy while you're interacting with our speaker. At the end of the presentation, there will be about 5 minutes for questions, which you can paste on the chat box. So our next speaker is Dr. Amanda BOLDERSTON from Nova Scotia, and the title of her speech is Advocacy in the 2SLGBTQIA+ community members affected by cancer and their leadership in the Queering Cancer Organization. Thank you so much for being here with us today, Dr. BOLDERSTON, and we're ready to hear from you.
Fantastic. Thank you, Georgia. Okay, everything look good? I hope so.
Yes, everything looks good.
Looks great on my end.
Thank you. So good afternoon, everyone, and thanks, Georgia, again, and SevTap and the organising committee for inviting me to speak to you this afternoon. These are the learning objectives for our session. So hopefully by the end of the session, you'll understand some of the health inequalities related to sexual and gender diverse people with a focus on cancer, to identify some inclusive care practices for the healthcare professionals amongst us, to improve experiences of sexual and gender diverse people in this area, and to discuss the role of my organisation, Queering Cancer, in advocacy and support. So why is this important? Well, Canada's home to approximately 1 million sexual and gender diverse people, accounting for about 4% of the total population, according to data from the 2021 census. Sexual and gender diverse identification has become much more common in the last decade, with many younger people seeing themselves as an identity other than straight or cisgender. Millennials are more than twice as likely to identify as sexual or gender diverse than previous generations. And in the US, a recent survey found that nearly 20% of Gen Z identify as part of the community. And what about experiences with healthcare? Well, historically, the healthcare system hasn't treated queer and transgender people too well. From unethical experiments early on to conversion therapy, which has only just been banned in Canada, and overt discrimination, there's a legacy of mistreatment and mistrust that can sometimes persist today. In a 2018 study from Nova Scotia, over a third of lesbian, gay and bisexual patients and half of trans patients reported having at least one negative healthcare experience in the last 12 months. So this can cause sexual and gender diverse people to become somewhat alienated from the healthcare system and reluctant to seek care. And perhaps it can affect how and when they subsequently access care, how they interact with healthcare professionals, and whether they disclose their minority status. So when sexual and gender diverse people experience healthcare, what are they afraid or concerned about? And how would they quantify a poor healthcare experience? Well, this is a US study from Lambda Legal, and in this study, sexual and gender diverse people were concerned about being refused medical care outright, when they disclose being treated differently by healthcare professionals, meeting professionals who have no training or little or no training in their needs, and trans patients, non-binary patients, have more worries across the board and concerns than lesbian, gay and bisexual patients. So in multiple studies, we see that this mistrust may be justified. This particular study was from 2019, and it found that more than 80% of medical students had an implicit bias against lesbian and gay people. In terms of the sexual and gender diverse population, these are some of the health inequalities that they face. They have higher rates of stress, which can lead to tobacco use and alcohol use because of a coping mechanism, lower rates of preventative screening and healthcare utilisation, increased risk of some cancers and chronic health conditions such as asthma and heart disease, an increased risk of poor mental health and suicidality, most commonly in youth who may be estranged from birth family. This can partly be explained by minority stress theory, and this was first proposed in the 1980s and since has been tested in about 150 empirical studies in different minority groups. It explains how marginalized groups, including sexual and gender diverse people, experience unique stresses that are due to their minority status. And these stresses can stem from external factors called distal factors, like discrimination, stigma, and violence, as well as internal factors, which are called proximal factors, like internalized homophobia or transphobia, expectations of rejection, and concealment of one's identity. And when the body undergoes a stressful situation, the stress hormone cortisol is released. Cortisol helps you prepare for a stressful and dangerous situation, and it gives you a quick burst of energy, heightened memory, and lower sensitivity to pain, among other things. But when cortisol is present in the body at high levels for an extended period of time, so-called cortisol dampening effects happen, and the body's immune system may be suppressed. Constant exposure to these stresses, therefore, can lead to adverse physical as well as mental health outcomes, as we saw in the last slide. Fortunately, there are some protective factors that can help minimize the impact of minority stress. These include community support, being accepted by biological family and having positive responses to disclosure or coming out, feeling good about being queer or trans or having low levels of internalized stigma, being accepted by a community of faith, living or working in a low stigmatizing environment, which just means an accepting environment, and having chosen family, which is a close network of support outside of somebody's biological family. So the last few slides are summed up by this quote from a lesbian affected by breast cancer in the study by Usher in 2023. And they said, being part of a marginalized community brings additional pressures and stresses, and the anticipation of potential discrimination or everyday misunderstanding is always there. This creates additional burdens which impact on health and well-being. So let's take a closer look over the next few slides at how cancer care is experienced by this population. And I've divided cancer up into the sort of typical 5 topic areas. So let's look at screening first. Well, sexual and gender diverse people are less likely to engage in routine cancer screening, and this may be for a number of reasons. They may be worried that they'll experience stigma and discrimination. An informatics issue is that the gender marker on a trans person's health record can incorrectly eliminate them from receiving the screening information and invitations that they may need. So an example is a trans woman with a female gender marker may not receive invitations for prostate screening. Where data is available for screening rates for trans individuals, the engagement rates are universally lower than the lesbian, gay, and bisexual population. This reflects the lack of evidence-based screening recommendations for trans and gender diverse people. And that's demonstrated in this example on the screen from colorectal cancer screening in the US. Gender dysphoria is the sense of distress a person may have because of a mismatch between their biological sex, or sex assigned at birth, and their gender identity. Screening invitations and procedure can cause gender dysphoria and anxiety over and above normally expected anxiety around invasive screening procedures, for example, a trans man having a pap test. And in general, there's just simply a poor level of understanding about these considerations among healthcare providers. Another barrier to screening is that screening campaigns are usually hetero and cisnormative, which means that they're aimed at straight cisgender people. Queer and trans people don't often see themselves represented in campaigns, so this may inadvertently relay a message that this isn't meant for me. The examples on the slide are targeted campaigns from the UK charity Outpatients, with trans and non-binary representation. My Cervix, My Service relays the importance that anyone with a cervix needs cervical screening, and the second image is a breast screening campaign called Best for My Chest. Because of lower screening rates, it's more common for sexual and gender diverse people to receive a later diagnosis, often meaning their cancer may be more advanced and harder to treat. In addition, the sexual and gender diverse community are at increased risk of certain cancer types. Lesbians and bisexual women are at higher risk of breast and cervical cancer. Gay and bisexual men are 20 times more likely than heterosexual men to develop anal cancer, and gay men with HIV are at 40 times greater risk for anal cancer. For subpopulations like trans and gender non-binary people, we don't really have any reliable data on cancer incidence and prevalence because we just simply weren't collecting it. So here's James's story. James was a trans man, and he'd been experiencing pelvic pain and unexplained vaginal bleeding for a couple of months. His family doctor requested an ultrasound at his local women's health clinic. Fearing discrimination, James didn't show up. He said, "I swept it aside until it got to the point that I couldn't ignore it." When he tried to access care, he was misgendered, leading to missed imaging appointments. One receptionist told him that this is a women's health clinic, you must be mistaken. Finally, after scans and tests, James was diagnosed with stage 4 endometrial cancer. So what about treatment? This is a 2015 study from the UK charity Macmillan, and it explored experiences of sexual and gender diverse people undergoing cancer treatment, and it found the following. Patients dealt with constant assumptions that they were straight and cisgendered, and they found it stressful disclosing their sexual orientation or gender identity, and many chose not to come out to their team. In fact, in a different study, we found that many patients actually disclosed their sexual orientation and gender identity to correct a misassumption by the healthcare professional. In the Macmillan study, there was a demonstrated lack of sensitivity from healthcare professionals and evidence of discrimination. And patients reported a near total absence of tailored support for queer and trans patients, particularly for their caregivers. And no surprise that this led to high levels of isolation and less satisfaction with care than cisgender and straight counterparts. So in survivorship, queer and trans patients have to adapt to their new identity as a cancer survivor and then integrate it on top of their other identities. And there's growing evidence that the layering of a new identity on top of being queer or trans can compound psychological distress in this stage. Recent US evidence found that queer survivors of adolescent and young adult cancers are more likely to experience chronic health conditions after cancer treatment, more likely to experience poor mental health and health-related anxiety, and more likely to experience poverty and survivorship compared to their cisgender and heterosexual counterparts. Navigating survivorship often means continued courses of treatment, aftercare and follow-ups, and there's still very little tailored support, particularly peer support, leaving patients feeling isolated and having to self-advocate. This is Tristan's survivorship story. Tristan is a trans man and ovarian cancer survivor, and he needs regular CA125 blood tests to ensure that his ovarian cancer is still in remission. Tristan's gender marker on the healthcare system in all documentation is male. However, the lab software restricted the CA125 test to females only, and Tristan's test was repeatedly cancelled, and he was sent away from the clinic. Tristan's advocated for the lab request system at his hospital and then in his province to be changed to allow the test to be available to everyone that needs them. When it comes to end-of-life care, sexual and gender diverse people continue to face many barriers and often access care late or not at all. There's a fear that entering a care facility or hospice may mean going back into the closet, and an assumption that sexual and gender diverse individuals don't ascribe to spiritual beliefs or practices, which is not often the case. Queer and trans people fear that chosen family will not be respected or recognised as next of kin, and partners often feel unsupported. This is from a 2016 report from a UK charity called Marie Curie called Hiding Who I Am. And this is David's story. This is David's partner speaking. "I knew he wanted a burial and he wanted to be buried next to his mother. He ended up being cremated, which was totally against his religion. I couldn't stop them, but it was like strangers organising his funeral. I was his family, but he never wanted to be known that he was gay, and I respected that. If he wasn't out, I wasn't out either. I couldn't talk to my family. They thought David was just a friend. I was a right mess. I had nobody to turn to." So we've looked at how cancer care can be potentially hostile and isolating for queer and trans people to navigate. So now let's explore how we can make the system a little bit safer and more inclusive, and there's 4 areas we'll look at. A key thing to keep in mind really is don't make assumptions, because when you meet somebody for the first time, obviously you don't know their sexual orientation or gender identity. So when it comes to designing systems, forms and processes, they should consider the needs of gender diverse people. Our electronic health records and our intake form should be adapted to include these 5 categories: sex assigned at birth, sexual orientation, gender identity, pronouns and chosen name. And given the expansive and changing language around gender identity, it's important to leave space for patients to self-identify and also to avoid using the word other as a tick box, because obviously other can be very othering. And sometimes we need all of this information and sometimes we need some of it, depends on the situation. So for example, if a trans woman is going for imaging, we need to know what kind of anatomy that we may be seeing in the pelvis. But if somebody's going for a broken wrist, we may not need all of this detailed information. It's very dependent on the situation. But at an organisational level, again, it's important for us to have anti-discrimination policies, and there should be a system for reporting discrimination or disrespectful treatment. It's also recommended to provide opportunities for patients to give feedback on how to improve, and of course that's important for all patients. So we know that having inclusive systems and policies like this helps people feel respected and valued and demonstrates our organisation's responsibility and commitment to inclusion. But it also helps us collect robust data and helps us address research disparities with research, and encourages disclosure should patients wish to disclose. So many studies that look at the experiences of this patient population and healthcare pretty much always call for better and more education for everyone involved in the patient pathway. But we do know that most healthcare professionals have very little education about the healthcare needs of queer and trans patients. In 2 US studies, medical students averaged about 5 hours in total, and this was mainly around AIDS and HIV, and nursing students had about 2 hours of curriculum content on queer and trans health in their training. And because education is pretty sparse, sexual and gender diverse patients often need to educate healthcare professionals that they interact with about their risk factors or health needs to receive appropriate care. So my advice really is don't wait to encounter a trans or non-binary patient before you learn about their healthcare needs. It's important for us to do some work on addressing our own personal biases, to do some work on understanding structural inequities and health disparities, and really to commit to embedding change in our own personal practices, but also to advocate for change in our organisations. An important step towards inclusive care is committing to using inclusive communication, which relies again on not making assumptions about gender, sexual orientation, relationships, or body parts. For example, in a new interaction with a person, you can start by introducing yourself and sharing your pronouns if you feel comfortable doing so, and then ask the patient, how would you like me to address you? Sharing your pronouns first shows that you're mindful of the fact that someone's pronouns may not match their appearance, and it demonstrates respect. It also helps create a more balanced interaction by offering personal information before asking about them. Using open-ended questions are always good, such as who is with you today, rather than is that your husband? And try to avoid using gendered terms like husband, wife, and use non-gendered alternatives to build trust, again, not making assumptions. A good tip is really just to listen to the patient and listen to the language that they use to describe themselves, their relationships, or their body parts, and then mirror that language. And of course, if in doubt, we can always just respectfully ask. On the topic of inclusive communication, people often panic about misgendering, which is wrongly assuming someone's gender by using the wrong pronouns or other gendered language. It can happen intentionally or mostly unintentionally, but either way, it can feel quite harmful. But my advice would really be, if you misgender somebody, just don't panic. Apologise with a very quick, I'm sorry. Thank the person for pointing it out if they did. And then really just move on. Don't expect that person to provide comfort because you feel bad about what you've done or to forgive you. It's not really about you. But commit to doing better. So how can you improve so it doesn't happen again? Maybe if it's a colleague that you've accidentally misgendered, you can practice talking about that person when they're not there, just to make sure that you're less likely to repeat the mistake. But we all make mistakes, and our intentions are universally usually good. Another pillar of inclusive practice is creating a welcoming environment where we work. And as a queer person myself, when I enter a new environment, particularly a stressful one like a clinic or a hospital, I look around the area for signs of safety, whether or not I need to come out. If I did come out, what would the repercussions be? Is this a situation where I need to disclose? A safe space sticker, a rainbow pin, or a rainbow lanyard on a healthcare professional can sometimes indicate to me that I can let my guard down a bit. Another really important part of a safe and inclusive and accessible physical space for everyone is all gender washrooms, which ensures everyone, regardless of their gender identity, can access a washroom without fear of judgment or exclusion. Inclusive patient education materials are important, posters, booklets, etc., with inclusive language and images of diverse bodies, diverse identities and relationships. Just a bit of a word of caution though, be aware of what sometimes is called performative allyship. So this would be just simply putting up a safe space sticker in your clinic or your environment without really having any appropriate education or underpinning inclusive policies, because these could be false signs of safety. And you can imagine if somebody saw that, felt comfortable, and then had a negative experience, perhaps from a receptionist, it would sort of be a bad start to their relationship with that healthcare environment. So to summarize, here's a quote from a research participant from a study from 2016, Nova Scotia. If I walk into a space where I see a poster on the wall where my identity is reflected, or I see a tick box on a form and I know that the healthcare provider expects me in the room, then I'm more likely to access these services again. So before we wrap up, I'd like to briefly tell you about my organisation, Queering Cancer, and you can see the contact information there on this slide.
Excuse me, Dr. Balderston, we have 5 more minutes until we go to questions.
Thank you. That's good. I think I've got 5 more minutes left.
Oh, perfect.
So we're at Queering Cancer. We're a Canadian volunteer-run community partnership, and we're dedicated to improving the experiences of sexual and gender diverse people affected by cancer. And we launched in 2020, so we're about 5 years old. This is our team, and we're all queer, trans, or non-binary. We're clinician researchers, psychologists, social workers, radiation therapists, and we also have community partners with lived experience. So that's Laura and Tristan. And Tristan's story was the one that you heard earlier. And this is what we do. We serve as a hub to collate and share resources and information, as well as educational courses, which we develop and deliver. We have a stories collection on our website, which we feel is really important because it's hard for queer and trans patients to find stories online about people like themselves. And when people are diagnosed with cancer or have to go through treatment, they often start looking for stories to feel connected to other cancer patients. We provide advice and consultancy for healthcare organisations about providing affirming environments. And we also do research. We do research as individuals and as a collective. We recently acquired a Canadian Cancer Society 3-year grant to look at improving the experiences of trans and non-binary people with gynecological cancer. So we're just about to start on the first phase of that. We're quite excited about that. We found that a lot of our engagement has been through social media, so formerly Twitter, but not anymore, now mostly through Instagram. And we regularly develop specific content. We do research recaps, we do tips for patients, we do tips for healthcare professionals, and we started dabbling in memes. And this is our website, queeringcancer.ca. So this is the version that we have now. We're just going through a rebrand and a retooling of our website. So this is going to change. But right now we have a fully searchable database of about 200 queer and trans specific cancer resources. As I said, we have about 70 plus patient stories right now. And these represent mostly first-hand experience from digital stories. We have comics, zines, anthologies. We have a whole bunch of different ways of presenting information and stories. We have an education page, which has links and resources for healthcare professionals or anyone that wants to learn more about this topic. Most of them aren't cancer specific, but they are healthcare specific, and most of them are free or low cost. And it's just a curated list of about 10, I think. We also have a blog and a newsletter that you can subscribe to where we share news and highlights and research. So just to summarize, as we discuss, the sexual and gender diverse population face inequalities in healthcare and challenges when they experience and access cancer care. So inclusive policies, communication practices, ongoing education, and creating a welcoming environment can improve experiences for sexual and gender diverse people. And I'd encourage you to find further education if you wish on this topic. So I mentioned our resources on queering cancer. There's also a really good resource on allyship from PFLAG, and excellent resources from our friends at the Princess Margaret Cancer Centre in Toronto from their sexual and gender diverse diversity in cancer care group. And they have some education modules, including one where you can actually practice inclusive communication in scenarios with diverse patients. And at the bottom, there's a link to a really good Australian resource, which was written for and with sexual and gender diverse people with cancer. And this is a list of references from the talk. And I'm really happy to take any questions or comments that have come up for you. And thank you for your attention.
Thank you so much for such an